Audio course on cervical shortening during pregnancy. Episode 7. Interventions Compared. This episode is where we put the tools on the table. Vaginal progesterone, cerclage, pessary, 17-OHPC, bed rest, tocolysis, steroids, magnesium. The mistake is to think of these as a menu for short cervix. They are not. Each tool belongs to a different phenotype, a different mechanism, or a different time horizon. The dominant model is this. Intervention choice depends on the patient phenotype, not the cervical length alone. Let us start with vaginal progesterone. Vaginal progesterone has the cleanest evidence for asymptomatic singleton short cervix before 24 weeks, especially cervical length less than or equal to 20 millimeters. SMFM recommends vaginal progesterone for that group. For 21 to 25 millimeters, SMFM recommends considering it through shared decision-making. Why does it make sense? Progesterone helps maintain uterine quiescence and opposes cervical ripening. In human labor, the issue is not simply low serum progesterone. It may be local functional progesterone withdrawal, receptor changes, and inflammatory signaling. Vaginal progesterone may act near the cervix and lower uterine segment, which makes it biologically plausible for short cervix. But do not overextend the mechanism. If the cervix is shortening because of advanced infection, PPROM, significant dilation, bleeding, or uterine overdistension, progesterone may not reverse the pathway. Mechanism gives plausibility. It does not erase phenotype.
The studied regimens matter. Fonseca used 200 milligrams of micronized vaginal progesterone nightly in women with very short cervix. Hassan's pregnant trial used 90 milligrams of vaginal progesterone gel in cervical length 10 to 20 millimeters. The Romero individual patient data meta-analysis supported reduction in early preterm birth and neonatal morbidity outcomes in asymptomatic singleton short cervix. SMFM notes that 90 milligram gel and 200 milligram micronized capsules are the most studied formulations, but evidence is insufficient to recommend one specific dose or formulation as universally superior. The resident reflex, vaginal progesterone, is a short cervix intervention in selected patients. It is not a generic cure for all preterm birth risk. Now, 17-OHPC. This is the intervention residents must unlearn carefully. 17-alpha-hydroxyprogesterone caproate is not vaginal progesterone. It is not recommended for treatment of short cervix. SMFM recommends against 17-OHPC, including compounded formulations for short cervix. ACOG's updated progestogen advisory states that intramuscular 17-OHPC is not recommended for primary prevention of recurrent spontaneous preterm birth. The teaching line is simple. Do not substitute 17-OHPC for vaginal progesterone because both contain the word progesterone. Now, cerclage. Cerclage is powerful when the indication is right and misleading when the indication is wrong. The three categories matter.
History-indicated cerclage is based on a compelling obstetric history, such as recurrent painless mid-trimester losses or prior exam-indicated cerclage. Ultrasound-indicated cerclage is based on a high-risk history plus current cervical shortening, usually prior spontaneous preterm birth and cervical length below 25 millimeters before 24 weeks. Physical exam-indicated cerclage is based on current painless cervical dilation, often with exposed membranes, after excluding labor, PPROM, infection, bleeding, and fetal conditions that change goals of care. If you cannot name the cerclage category, you are not ready to recommend cerclage. Now, evidence. The TOE trial in broadly screened women with cervical length less than or equal to 15 millimeters did not show a broad benefit from cerclage. That supports SMFM's recommendation against routine cerclage for a no prior spontaneous preterm birth singleton with cervical length 10 to 25 millimeters and no dilation. Owen 2009 is different. It studied women with prior spontaneous preterm birth before 34 weeks whose current cervix shortened to less than 25 millimeters. Overall benefit was not uniform.
but previable birth and perinatal mortality were lower, and benefit appeared concentrated in the very short subgroup, especially less than 15 millimeters.
FIGO recommends ultrasound-indicated cerclage for cervical length below 25 millimeters in women with at least one prior spontaneous preterm birth or mid-trimester loss. NICE offers a choice of prophylactic vaginal progesterone or cerclage when both prior spontaneous preterm birth or loss from 16 to 34 weeks and cervical length 25 millimeters or less are present. So the clinical synthesis is this. Cerclage is not for every short cervix. It is for selected histories, selected ultrasound phenotypes, and selected dilation presentations. Now, pessary. Pessary teaches trial humility. The mechanism is attractive. A pessary might change the uterocervical angle, redistribute pressure, reduce opening of the internal os, or protect the mucus plug. It is non-operative. It feels reasonable. Goya's PCEP trial was strongly positive in singleton short cervix, with a large reduction in spontaneous delivery before 34 weeks. But Nicolaides' large trial did not replicate a benefit. SMFM recommends against routine cervical pessary for singleton short cervix prevention. In multiples, ProTwin did not show overall benefit, though subgroup signals appeared.
Support 2024 compared cerclage, pessary, and vaginal progesterone in singleton pregnancies with cervical length less than 25 millimeters, mostly with risk factors. Preterm birth before 37 weeks was not significantly different among groups. About 30.5% with cerclage, 31.2% with pessary, and 24.2% with progesterone. This suggests no clear superiority in that trial population, but it does not collapse all guideline distinctions. It was not a license to ignore history, dilation, twins, or local practice. The resident reflex. Plausible device plus one positive trial is not enough for routine practice when later evidence is inconsistent. Now, bed rest. Bed rest is an intervention too, even though it is often prescribed casually. It has harms and no proven prevention role for isolated cervical shortening. SMFM consult number 50 recommends against routine activity restriction for shortened cervix or preterm birth risk. ACOG Committee Opinion 804 says activity restriction should not be prescribed routinely to reduce preterm birth. AWARE 2026, using accelerometers in patients with short cervical length, found no latency benefit from sedentary activity, and fewer than 3,500 steps per day was associated with earlier birth and higher preterm birth before 34 weeks. So do not say it cannot hurt. It can hurt. Now, tocolysis, steroids, and magnesium.
These are often mentioned in the same conversation because the cervix is short and everyone is worried, but they are not primary treatments for asymptomatic short cervix. Tocolysis is a short-term tool for threatened or established preterm labor, usually to gain time for corticosteroids or transfer. It is not long-term prevention for a closed short cervix. Antenatal corticosteroids are used when preterm birth risk is sufficiently high in an appropriate gestational window. A short cervix alone does not always mean delivery is imminent enough to justify steroids. The decision depends on gestational age and short-term delivery risk. Magnesium sulfate is neuroprotection when early preterm delivery is anticipated, often before 32 weeks, depending on protocol. It is not a treatment for cervical length. GBS prophylaxis belongs to threatened preterm birth management, according to local protocol. Antibiotics are not indicated for preterm labor with intact membranes, unless there is another infection indication. PPROM is different. Now, let us build a tool by phenotype map. No prior spontaneous preterm birth singleton. Closed cervix, less than or equal to 20 millimeters before 24 weeks, vaginal progesterone. No prior singleton, 21 to 25 millimeters, consider vaginal progesterone through shared decision-making. No prior singleton, 10 to 25 millimeters, no dilation, do not place cerclage routinely.
Prior spontaneous preterm birth plus current cervical length below 25 millimeters, Discuss progesterone and ultrasound-indicated cerclage, especially if the cervix is very short and the prior birth was early. Classic recurrent painless mid-trimester losses? Think history-indicated cerclage. Painless dilation with intact membranes and no infection, no labor, no bleeding? Consider physical exam-indicated cerclage in the right setting. Twins with short cervix? Use cervical length for risk stratification. Do not routinely use progesterone, pessary, or cerclage outside trials, according to SMFM. Short cervix with contractions? Triage for preterm labor. Short cervix with leakage? Evaluate for PPROM. Short cervix with bleeding? Do not treat as uncomplicated. Now a case. 21 weeks, singleton, no prior preterm birth. Cervix 18 millimeters, closed. Best supported tool, vaginal progesterone. Not cerclage, not pessary, not 17-OHPC, not bed rest. Second case. 21 weeks, prior spontaneous preterm birth at 29 weeks, cervix 14 millimeters. Now cerclage is a serious option, and vaginal progesterone strategy is also relevant. The prior history and very short cervix change the tool selection. Third case. 22 weeks, twins, cervix 18 millimeters, closed. High risk, but SMFM does not recommend routine progesterone, pessary, or cerclage outside a trial. Use MFM judgment and surveillance, not singleton reflexes. Fourth case. 22 weeks, 3 centimeters dilated, membranes visible.
Do not reach first for progesterone. This is possible exam-indicated cerclage after excluding labor, PPROM, infection, bleeding, and fetal conditions. Let us close with the resident reflex. Do not ask, what do we do for a short cervix? Ask, which short cervix is this? The right intervention is not chosen by the millimeter alone. It is chosen by phenotype. History, gestational age, plurality, symptoms, dilation, membranes, infection, bleeding, and the treatment window.